All right, here we go. PO, actually, people will say it means per oral, but it actually means per os, which is, os means opening. Okay, so that's by mouth, obviously. Do not give PO meds to people at risk of aspiration. So these would be like our post-stroke patients or maybe MS, myasthenia gravis. If they're having a hard time swallowing, they're going to choke on it, aspirate on meds, and you really don't want that. Okay. If a patient is actively vomiting, is now the time to give them PO meds?
No.
No. If they are heavily sedated, can they swallow very well?
No.
No. If they are unconscious, please do not give PO meds. Okay. If they have any kind of difficulty swallowing, this could even be like our Parkinson's patients, like people that have a hard time swallowing should not be given PO. Now in PO, that one's a little tricky because sometimes they will allow some PO meds, like with a tiny sip of water. So if you get an order that says PO and you know your patient's in PO, you just need to verify with this physician that it's okay to do that. Okay. Let's see. If you are using a syringe, like if it's a liquid medicine, make sure that the patient is upright. If they're laying backwards, what's going to happen?
Choking.
They're going to choke. We don't want that. You do not squirt it straight back in their mouth. It will hit their uvula, they will gag, and they will vomit. You put it in between her, okay, towards the back, in between the gum and the cheek for them to swallow. Okay, do not ever put it straight back and make sure they're upright. Okay. If you are giving a sublingual, what is a sublingual medication?
Under the tongue.
Under the tongue. Yeah.
Tongue, or if you're giving buccal or buccal, some people will call it, where does the buccal medication go?
Between the cheek and the gum.
Okay, give them water first, not afterwards, because if you give it to them afterwards and they're going to swallow the med, it's going to go in the GI system and it won't absorb well. Okay. Different preparations you may give orally. You could give a liquid, which they may say solution, suspension, or syrup. Now, who do you have to be careful giving a syrup to?
Wait.
When you think the word syrup, what do you think?
Like honey thick.
And sweet, yeah?
Yes.
Who do you want to be careful giving it to?
Diabetic patients.
Diabetic patients. That was easy, huh? Diabetic patients. The other thing too about some liquid meds is not only are they very sugary, but a lot of them have alcohol put into it in order to kill certain bacteria, in order for it to stay for a long period of time. Like a lot of cough syrups have alcohol. Do not give that to alcoholic patients. They will fall off the wagon and it is all your fault. Okay. Tablets, if they are scored, that means they have the little line in them. Those you can break in half if it's a big one. Okay, but it would have to be scored. Scored tells you that it can be broken in half. Enteric coated. What is an enteric coated medication? I can't hear you, Carly. It says you're unmuted, but nothing's coming out of your mouth.
Can you repeat that?
Yes. What is an enteric coated medication?
So it's like coated in like a specific like gelatin like coating. I don't know if it's gelatin, but it's
a hard coating, but what's its purpose?
It's to be absorbed in the stomach.
In the small intestine, not the stomach.
Oh.
So if it's enteric coated, it's coated with a coating that does not dissolve in stomach acid. So those are patients that we don't want the medication to absorb in the stomach. We want it to go through the stomach, be unabsorbable in the stomach, get down to the small intestine where the pH is different and it absorbs there. One of the most famous ones that are enteric coated is aspirin, right? Because we know aspirin tears up stomachs and it can cause peptic ulcer disease. So if patients already have peptic ulcer disease, they'll give them enteric coated aspirin. They'll still take it by mouth. It'll go into the stomach, but it won't be absorbed there. It'll go into the small intestine and be absorbed there. But you cannot crush or break those, because if you crush them and break them, then it will be absorbed in the stomach and it'll cause problems in their stomach. Do you understand?
Yes.
Never crush or break enteric coated. Sublingual, you already said was under the tongue, and then the buccal is in between the cheek and the gum. And sometimes those will come as a like a lollipop. It looks like a lollipop. They have these with fentanyl. I mean, how great is that? So fentanyl is a massive opioid, and you can literally just take like a little lollipop and put it at the side of your mouth. There you go. Okay. Do not crush or break anything that is enteric coated. You cannot crush or break SR, ER, CR, SA, or LA. All those are different ways of saying that they're meant to go through the intestines and they're meant to secrete a little bit of the medication over time. So there's little balls inside of these, okay? So they look like a little capsule and there's little teeny tiny balls inside. And they are going to release at certain times during the day. So if you open them and put them in applesauce or pudding or something, it's going to give it all to your patient at one time and it ruins the whole purpose of the medication. So those you can never open. Do we understand? Okay. When you're giving meds to older adults, make sure you sit and take your time. They have a lot of questions and it can sometimes be difficult for them to swallow or to take a lot of medications at one time. I hate this next thing, but they always test on it, okay? And it's super weird. If they have a hard time swallowing and you're giving PO, you're supposed to massage right here, which I tried it and I'm like, this is horrible. But like if they're swallowing it, you're supposed to like gently massage like this to help the pill go down. This sounds awful to me, but they always test on it, so I included it here today. You stay with your patient the entire time you're taking their meds. You can make sure they get taken and then do a medication reconciliation. We talked about that earlier to make sure that everything is on the mark. What is polypharmacy?
Where you're taking many meds at once.
With a lot of side effects that can interact with each other. So you have to be careful of adverse effects or side effects with polypharmacy, especially with older adults. Set up their home med schedules. So that's why you do medication reconciliation, is to make sure that you are doing their medications at the same time they're going to take them at home. And then teach them the proper drug names, because you will always have older adults come in and say like, oh, that's my water pill. Well, there's a million types of water pills, right? So they need to know Lasix or furosemide or whatever the actual name of the drug is, okay? For kids, you got to make it fun or they're not going to take nothing, okay? Give them a choice, but it has to be choices you can live with, okay? So you can't say, do you want to take your meds now? Because they're going to be like, no. And then you're like, well, shit, they have to take the meds now, okay? So give them choices you can live with. Do you want to take the blue one first or do you want to take the red one first? That's a choice I can live with. I don't care which one they take first, right? For children, you cannot put meds in a bottle or a cup because you do not know how much they're going to take. So what if they take 2 drinks out of their milk and they're like, I don't like it? Then how much med did they take? I have no idea. Can I give it to them again? No, because I don't know how much they took. So we don't mix for kids. Okay. Now you can offer them a chaser. You'll know what a chaser is, I'm assuming.
What is a chaser?
Like, okay,
Like you take
usually
it.
if you go to a
Can you
bar,
hear me?
you take like a shot of tequila and then you take like usually you do a lime, but a chaser is like something that you can take afterwards that makes it not taste so bad. So for a kid, I wouldn't mix it in grape juice, but I would say, here, take the medicine really, really fast. And then here's a drink of grape juice afterwards. So then it doesn't taste so bad in their mouth. Okay. But you can't mix it with like 4 ounces of grape juice or something, because what if they don't take it? Because inevitably the kid loves grape juice. You put it in 4 ounces of grape juice and they're like, I don't like it. I'm not taking it. Oh my God.
Can you hear me now?
Yeah.
Okay.
Allow the child to self-administer. Now, even babies can take their own medication. Okay. So my daughter took a lot of medicines when she was young. So when she was 6 months, 7 months, I could hand her the syringe. She would put it in her mouth and go whoop, and take it herself. Kids will always like to do things better themselves. So always give them that option. Okay. Involve the parents. That's helpful too. So when you go in with the meds, you can say, do you want to give this medication or do you want me to? But you still have to stay in the room the whole time they give it. Because kids may take things better from their parents than from you, or it may be the other way. The parent may say, she won't take that from me, you give it to her, you know? And if the kid really likes you, they may take it for you really well. All right. With infants, we use a dropper. Do you know what I'm talking about? It looks like a little syringe and it has the little numbers on it. We never, ever, ever use household spoons. Okay. Your parents probably did this when you were young. My parents did this. They would take like, Robitussin or something and be like, here's your purple medicine. And they'll put it in a teaspoon. Well, we have these big ass spoons in my house. So I probably got 8 times the dose. We all slept really well because, God knows how much they actually gave us. So you always want to actually use a dropper, the little droppers or syringes for kids, because it's much more accurate than a household spoon. Okay. There are some medicines you can mix in a soft food. And that would be like, I can put like a little bit of pudding and then put the medication in with a little bit of pudding and then they take 1 bite. If the kid's older, and I know for sure they'll take it. We've mixed medicines with like chocolate syrup or peanut butter or like something that tastes good to kind of give it a little taste. But it would have to be something they can take all at one time. You understand what I'm saying? Okay. Popsicles are really helpful afterwards. You're like, hey, we take your meds and I'll get you a popsicle. Do you want a red one or do you want a green one? And they're like, oh my God, I want a green one. Or like if they're a preschool age, giving them a sticker afterwards is helpful. They need something to help them to take it. Because adults, we understand, like, I have to take this medication because my heart isn't working correctly. Kids don't give a crap. They'll say, it tastes bad, I'm not taking it, and that's it. You understand? All right. If medications taste terrible, and this could be for older adults too, or for anybody, like some adults would be like, I'm not taking that. I don't like the taste. You're like, okay. So if it's not a kid, we can mix it with something like orange juice is good because it has kind of a strong taste. Pudding or applesauce is good to mix some medications in. This one is so stupid, but it's in the book, so I mentioned it anyway. Have them put ice in their mouth for a few minutes before administration so they don't taste it as much. Dumb, but whatever. You can use a chaser. Refrigerating the med makes it taste better. I don't know if y'all have ever had room temperature meds, but they taste nasty, like amoxicillin. So like those are gross. So refrigerating it can help a little bit. And then offer them oral care immediately afterwards to get some of that nasty taste out. Like one of the ones that's notorious for tasting terrible is potassium. It tastes awful. So they'll usually mix that in a little bit of orange juice to kind of cut the taste a little bit. All right, what are enteral medications? What are those?
Things that are like
administered through a tube, like an NG tube.
Or anything that goes, enteral medications or any type of way you can administer it that goes into the GI system. Okay, so enteral medications can be oral, NG tube, OG tube, PEG tube, it's just getting into the GI system. Okay, so NGT is NG tube, OGT, oral gastric tube, PEG tube is the tube that goes like sort of like a G tube. It goes directly into their stomach and you can put it through a syringe. Okay, so anything that ends up in the GI system is called enteral medications. Are we clear? When you're doing enteral medications through a tube, liquids are always going to be better. Now, some hospitals will let you crush pills and dilute it with water and pull it up. But the only issue I have with that is it gets clogged really easily when it goes through a tube if you're doing a pill. So is it possible? You'll have to ask the pharmacist if you can crush that specific pill. And then you mix it up, draw it up, and then give it through the tube. Okay. Some capsules can be open. So there are some that you can open and it's like a powder inside. So those are easy to dilute because they'll mix pretty well. But again, you need to ask the pharmacist if that's one that can be opened because you don't want to open the sustained release or the extended release or any of those. Okay. When you are giving enteral meds, now this is important, meds that taste bad, we want to refrigerate. Meds that go through a tube, you want to give it room temperature because the patient is not prepared, meaning like if you're putting it through a tube, usually when we give oral meds, your mouth will heat it up, right? When you're giving it through a tube, there is no heat. So if you put something ice cold on their stomach, they may vomit it. So if you're giving it through a tube, you want to make sure it's at room temperature. Okay, are we clear on that? Always check placement before. Even if you just gave a med 5 minutes ago and you're giving another one later, you have to check the placement of the tube. Now, PEG tubes and G tubes do not require tube placement because they're surgically implanted. But an NG tube or an OG tube can travel anywhere. It can go into the lungs, it can go anywhere. So you have to check placement. How do we check placement of an NG tube or an OG tube?
aspirate. It's like stomach contents.
So the
Check for
first time we check
gastric
placement,
ritual.
we do a chest x-ray the first time.
Mm-hmm.
And then after that, we will aspirate the gastric contents and put it on pH paper. What should the pH of your stomach be?
Acidic.
So
Less
like
than-
how acidic?
Like stomach kind of like very acidic.
Yes, like how is like what is a number I'm looking for?
Like
3.
3 or 4.
Like 3 or 4. Yeah. And that would tell me that, hey, this is super acidic. I'm obviously not in the lungs. Okay. You need to flush the tube with water before and after. Okay. To make sure that the med got through. And you'll see this done incorrectly in the hospital all the time. They'll push it through a tube and you can literally see the med in the tube and they're like, I don't know why the patient still has pain. Ma'am, it is sitting in the tube, it is not in their stomach. So you need to flush it afterwards. Please make sure you choose water to flush with. When people think flush, automatically your mind goes to flushing an IV and you'll want to pick normal saline. Please do not give salt water to your patient through a tube. Okay? All right. If a patient has an NG tube that is to suction, and then you need to give a med through the NG tube, then you need to stop the suction, take it off the suction, check the placement, right? Flush it with water, and then give the med, flush it again, and then clamp it for 10 to 30 minutes. Because if I connect it right back to suction, what's going to happen?
It's all gonna come out.
It's going to go right back
come
into
out.
the suction. So it needs to be clamped for about 10 to 30 minutes afterwards. Okay. Please make sure when you're giving a med through a tube that you check medicine to medicine and food compatibility. So you want to make sure that it can be given when they have a feed. Now, sometimes you'll see nurses flush multiple medications through a tube. That's okay, but you have to make sure the two meds are compatible with each other. Do you understand? All right. Questions on oral meds?
No.
Yes, no?
No.
Great. All right. And yeah. All right. Topical meds. Now, people have a misconception that this is just skin, but it's not. It can be skin or mucous membranes. Where do you have mucous membranes?
Mouth, eyes, ears.
Nose.
Where else? Vagina.
Oh yeah.
Yeah.
Those are mucous membranes too. So any mucous membrane is highly permeable, meaning it can absorb very well. Okay. If you're going to give a topical medication on the skin, okay, clean the skin obviously before administering, and please wear gloves because ew, even if you're doing lotion on a patient, come on now. All right.
Ew.
Yeah. Now you can just use clean technique unless there's an open wound. If you're applying medications to an open wound, it needs to be sterile. Okay. Because, well, all right.
Sepsis.
Formulations for topical meds for the skin. Now, powders is a big nursing red flag. Can we use them? Yes, but do not go over and do this on your patient because they will inhale a powder. So I don't know, Johnson & like powder used to be very common. They powdered the hell out of every baby at every diaper change back in the 70s and the 80s. You had a baby, you clean them off, and then you put ridiculous loads of powder and you put the diaper back on. Well, these babies were all inhaling this powder, okay, and a lot of powder, it got absorbed into the skin. And Johnson & Johnson had this massive, and it's still going on, lawsuits where it caused ovarian cancer in the little girls if they put tons of powder on. So you do not want to do powder around your patient, okay, and make sure that your face is away from it because you don't want to pour it. What's better is to take the powder, put it in your gloved hands like this, kind of rub your hands or pat your hands together, and then apply the powder to wherever you're putting it on the patient. And a lot of times you'll see powder like our patients that are in the hospital for a long time, they'll get yeast infections underneath the breasts because it's hot and it's sweaty underneath there. So don't just go lift up their boobs and go like this, okay? Because they'll inhale it, okay? This is a giant red flag for nursing. So can you use a powder? Yes, but do not use it around yourself or your patient, okay? If it's an ointment, y'all know that's the thick, oily stuff. Just make sure you rub it in really thoroughly because it's made out of an oily substance. And so that oil will just sit on top of the skin if you don't rub it in really well. Creams, you should do at room temperature because nobody wants freezing cold ass cream on their skin, right? That's super uncomfortable. Lotions always need to be, they shake first and apply them with either cotton balls or gauze, which is so weird, but that's how we do it. You will have questions on patch care all through nursing school. So it is very important that you know transdermal patch care, okay? We're gonna put it on clean, dry skin, hairless skin. Do not shave the area. What happens if I shave the area I'm about to put a patch on?
That causes
Irritation
or
when you're shaving, it causes little micro abrasions in the
Oh,
skin.
yeah.
Then what happens if I put a patch on it?
It's
that's gonna cause ingrown
You're-
hairs or
It's
something.
gonna
It's gonna
absorb
go
it
inside
too quickly.
yeah.
Yeah, it's gonna absorb much more than it normally should. So you need to find a hairless area, and on some men, this is very challenging. okay? Because you can't shave it. You're gonna wash the area with a mild soap and water, pat it dry, and then apply the patch. You have to wear gloves, because if you touch the patch, you're gonna get that medication. And they've had nurses fall out putting on a nitro patch because it decreased their blood pressure so much. So always wear gloves when you put on a patch. Rotating sites is very important because they are really irritating, okay? So you have to rotate sites all the time, okay? When you put the patch on, you have to hold it on for 10 seconds, okay? You are gonna label it with tape, but do not write on the patch itself. How come?
That
Because it will
patch still has the
interfere with the-
medication and
Yeah.
just
Because it could interfere
that
with the
can, like-
medication, like absorbing into their skin.
Yeah, it can absorb into their skin. And that's ink, so we probably ought not. You wanna give them a permanent tattoo?
no.
That
people
says
might want it.
12/2022 at 11:30.
Hey, maybe they want to know when they got their nitro patch.
Exactly. All right, the other one is do not apply heat, and they're gonna make this sound very nice on a test. Patient is experiencing mild irritation at the site. What do? A, apply gentle, nourishing heat to the area to heal it. You're like, "Oh,
Nourishing.
that sounds so nice." But what happens when I put heat on a patch?
It interferes with the absorption.
It will
opens,
vasodilate,
yeah.
which is going to cause them to absorb. It's also really irritating when you apply heat. Number 3, a lot of the patches have metal in them. Do you want to heat up metal on someone's skin?
No.
No. Okay, so do not apply heat. Watch the area for skin irritation. Please, this is very important. Make sure you remove the patches before an MRI, or if you're defibrillating the patient. Like I said, some of them have little pieces of metal in them. What happens if I shock somebody with kabillions of joules of energy when they have a patch on?
I'm gonna go to that piece of metal
And
and
you're
like
gonna burn the
explode
shit
it.
out of them through
Yeah.
the patch. Okay. Usually they can bathe and swim with it, no big deal, because if you have to take it off when you're swimming for 5 hours, it kind of defeats the purpose. So most of them are waterproof. Okay. All right, with the eyes, when you're doing, now they are very specific on these on exams. So everything I write on here could be testable. Okay. When you're doing an ointment, y'all know that's the thick, oily stuff, right? It needs to go down here in the lower conjunctival sac. Okay. 1/2 inch. Okay. You're going to put it in 1/2 inch, like, so it's, this much ointment all the way across from inner to outer campus. So you're going to pull this down with gloves, obvi. Pull this down, and then you're going to apply it from the inside to the outside. You're going to let it go, and they're going to move their eyes around once they close them. Now, when they open, it's oily, so their vision's going to be blurred. So if they're like, I can't see, you're like, it's all right, man. You'll be okay. You understand? When you're doing drops, wear the gloves. You clean their eyes first. Always pick inner to outer campus. They love this question. You'll see it all through nursing school, inner to outer, because otherwise you're wiping junk back into their eye. Okay. Tilt their head back just a little bit. Do not ever touch the bottle to their eye, because that's gross. Okay. Again, you're going to pull down the lower conjunctival sac. Okay. You're going to rest your hand on their forehead to administer this way. So just so you're steady. Okay. Do not touch the cornea. You can scratch the cornea and give them a corneal abrasion. Okay. Once you put the drops in, you're going to put pressure right here, because y'all know you have a tear duct right here, right?
Mm-hmm.
And it will go into the tear duct and it will absorb systemically, and I don't want that. So you're going to hold pressure for like 30 seconds or so. Okay. And then afterwards, give them some tissues to like blot it. Okay. Ears, they love these on exams, and you'll have this all through nursing school. So they're going to sit like this. Okay. And for adults, children and children under 3, you have to know how to position the ears. So for adults, you'll take the top part of the ear and pull up and back. And this is from the shape of their ear canals. This is why you do it. On a kid that's over 3, you pull straight back. Okay, you're like this, right? And on a kid that's under 3, you're going to pull down and back. And that's to help the ear canal straighten out, so it will go directly into the ear. Do not put it straight back. Like we talked about, don't put it straight into their mouth. If you put it straight into the ear canal, it's going to go right onto their tympanic membrane. It's going to irritate it. So when you do it, you're going to pull the ear back, and you're going to try to put it on the side of the canal, so it'll just kind of like drip down the canal rather than straight in the hole. You understand what I mean?
Mm.
Okay. And then you're gonna have them stay in this position for like 5 minutes. Otherwise, because if they sit up like this, it's just gonna drip straight out, right? You can press the tragus just a couple of times just to kind of try to get it down the ear canal. The tragus is that little piece right there, okay? Always administer sterile solution, so make sure it's sterile, not your gloves, just sterile solution. And then it's at room temperature. What happens if I give eardrops that are cold?
It'll make them dizzy.
It's,
And
yeah,
they'll
it's gonna
puke.
make,
Yeah. So how do I warm them if they're cold? Rub them in your hands, not the drops, the bottle. Don't shake, rub. Okay. Please do not put it in the microwave. That is not a good idea. Okay. All right. Nose. If you're doing the drops, the head goes back a little bit. Do not touch the bottle to the nose. So if you're noticing on all of these, we don't touch the bottle to like anything. Okay. Have them blow their nose before you administer it, so it's nice and open. Okay. If you're doing the spray, now in your book it says to put their head backwards. I don't agree with that, so I said head midline, because if you put the head backwards and you spray, it's going to go down their throat and it's going to taste horrible. Okay, so usually we just have their head midline. Occlude the other nair, so you're going to hold this one, have the patient breathe in, and you're going to go, and they're not a big sniff. If they go, where's it going to go?
Oh my gosh, I do that all the time when I
Well,
use that
stop it.
nose stuff. I do
Yeah,
it.
it goes
and
down
I
your
taste
throat,
it.
doesn't it? Yeah. So if you sniff really big, it's going to go down their throat. And if they say they can taste it, then they've sniffed too hard. Okay. It should be a baby sniff.
So does that make it not work then?
Yes. It goes straight down your throat and it does not work. Okay. If you're doing a nasal spray, honestly, if you're giving it at home, you need to tuck your head and then just spray it and don't sniff at all. Like if you do have to, then like teeny baby sniff.
Okay.
This, like a crack addict, is going to make it go straight down your throat. You'll taste it. It's
I'm sure that's what I look like, a crack
It'll give you
addict.
a really bad sore throat. Okay.
Great.
Okay. All right. Do we understand these topical medications?
Yeah.
Don't
yes.
mind if I keep going because I can be done soon. You
Yeah.
have anything to do? Okay. All right. Next. Let's see. One sec. All right. Let's talk vagina and rectums.
Yes.
Anything you can give in someone's mouth, you can also put in the vagina or the rectum.
Noted.
Yeah, noted. Yeah, we saw this happen a lot. It's a mucous membrane. It's made out of the same thing as your mouth is, okay? And it will absorb. Like there was a problem we had with teens for a while that were taking tampons and dousing them in vodka and then putting in the tampons and getting super drunk.
Are
Without the
they giving
calories.
that in their vagina and their butt too?
Uh-huh.
What?
Yeah.
Why would they
Anything
drink
that can absorb in your mouth can absorb in because the vagina, the rectum, and the mouth are all made out of the same tissue.
And if they were doing it like that, then their breath wouldn't smell.
Exactly. Everybody won, except for them. Okay. So if you're giving something vaginal, okay, it can come as a cream. Now, usually that will come with an applicator, like a Monistat or something like that. There are some foams that can be applied. And there are like tablets, but they're really like little suppositories. And those also have an applicator because you have to put it far enough into the vagina so it won't like come out if they cough or sneeze or something. Okay. The suppositories do need to be refrigerated because the way that they melt is heat, right? So as soon as you put it in the vagina, it's warm in there and it will melt. That's how it's absorbed. Okay. So before you go to do something vaginal, make sure the patient pees first. Otherwise you're going to have a very uncomfortable time. Okay. Because it's already really uncomfortable anyway. Please, for the love of the Lord, wear gloves. Okay. I know I probably don't need to say that, but just really important. You're going to put them in the lithotomy position. What's the lithotomy position?
Like legs
Like,
up.
Knees
when
up.
when they're giving birth, like giving
Yeah, like a giving birth position. Okay. Clean the labia from front to back. Always pick front to back on our lady parts. Okay. After you clean, put on new gloves because your gloves are now dirty because you didn't clean their outside area. Okay.
While it was dirty.
Be nice and lubricate the applicator because applicators are plastic and that don't feel right. Okay. If you're just giving a vaginal suppository, then just lubricate the end of that, but it has to be a water soluble lubricant. You can get the KY jelly out of Omnicell. Okay. So you can go and get that out and then just make sure that you lubricate it really nicely. Okay. The applicator or the suppository needs to go down and back because that's how the vagina naturally curves. Okay. You have to push it far enough in so that it will not come out. Okay. So fingers width is fine. If it's an applicator, after you have lubricated it and you put it in down and back, then you push the plunger slowly. Do not jam that in. That is uncomfortable for everyone. Okay. If you're doing a suppository, insert it with your index finger and you go in a finger's length. Got it? And then the patient needs to lay there for about 5 to 10 minutes so that their body heat can melt this. Do we
And
understand?
they lay in the lithotomy position, right?
They don't have to. They can lay
Oh,
in
okay.
whatever position. Yeah, they're probably not comfortable in the lithotomy position, so I would just position them in another way. Okay. All right, when we're doing rectal, usually those come as suppositories, but there is some liquid we can give rectal too. Okay. Please again, wear gloves. Put them in the Sims position. What's the Sims position?
It's on
Like
their
it-
side with
they're-
the
like
left
they're-
leg up, right?
Yeah, like your sleeping position with your leg up so you can reach their bottom hole. Okay. You're going to go in about 3 to 4 inches. So again, the length of a finger. There are 2 sphincters inside the rectum. You have to feel both of them going through. If you just put it through one
Ooh.
sphincter, which is the outside sphincter, then it's not going to go far enough in. Okay. It won't melt very fast. And usually if they poop afterwards, they're just going to poop out the whole suppository. So you will feel that there are 2 rings in there and you go whoop, whoop through both of them. Carly's face is like,
Ew.
you don't like the word sphincter?
No.
All right. After you have inserted it, clean around the anus because usually there's like lubrication and maybe a little bit of dookie or something around there. So just be nice and clean them up, you know. And then they need to stay on their side for at least 5 minutes and you tell them try to hold in the suppositories for as long as you can because if they do poop, the suppository will come out if it, what?
Tell them to clinch.
Yeah. Yeah. Just be like, I know it's uncomfortable, but try to hold for as long as you can. People that you do not put stuff in their bottom. Okay. If they have thrombocytopenia, what's thrombocytopenia?
Low.
White blood cells.
Low platelets,
Platelets, which means they're at risk of,
bleeding.
Bleeding.
yeah. You do not want somebody to bleed out their bottom. That is not the way to go. Okay. So if they are at risk of bleeding, leave their butthole alone. Are we clear?
Yes.
Okay. If they have a AAA, what's a AAA?
Abdominal
Yes.
aortic aneurysm.
Yes.
I was like, there's gotta be
Abdominal
something that has
aortic
3 names in it.
So they have a big ballooning out of the abdominal aorta. And if they push, because they're going to push whenever you put a suppository in there. Because as soon as you put something in the bottom's like, this is exit only, and it's going to clinch. Okay. That increases the body's pressure. The Valsalva maneuver will increase pressure, right? So it will cause the aneurysm to rupture. Okay. If a patient has increased ICP, do you want them going, ugh? No, because it increases pressure. They'll blow out their brain. An MI, the Valsalva maneuver decreases heart rate. If the patient's coming in with an MI, oh my God, is that your mom? Did she hear me? I'm so embarrassed.
No, that was my sister.
Okay, we'll still tell her sorry for the grunting noises. Okay, if they're
Got
having an
headphones
MI,
on.
yeah, but you just never know. And their heart rate, let's say, is already 40, and then the Valsalva decreases their heart rate. That's why we tell patients with an MI, when they come in, we will tell them, do not push to poop or you will die. This is how MI patients die on the toilet. Hello, Elvis. Okay, because they Valsalva and it tanks their heart rate, and their heart will just stop. They'll go into cardiac arrest. So probably ought not. Okay.
So that's what he
Bradycardia, same thing. If they have bradycardia and they Valsalva, their heart rate will be 20. They won't get perfusion and they'll die. Nobody wants to die on the toilet. Okay. Infants, we do not do per rectum usually with infants because their bottom holes are so teeny tiny that even if you use your pinky, you can still sometimes rip the outside area. Okay. What about meningitis?
Well, because there's already inflammation in the brain. There's like meninges. There's probably pressure.
There's increased pressure. So if they push, it's going to increase the pressure in the head.
And those patients are on contact precautions, so you can't, you want to stay like away from them. You don't want
to dig around in their butthole. Yeah, probably not.
Okay,
Spina
even
bifida.
if they're not on contact precautions, do you want to dig around in their buttholes?
Well, nobody wants to, but you sometimes will have to, even if they're on precautions. just double glove.
Yeah.
Spina bifida. We don't know about spina bifida.
It's a birth defect.
Of the what?
The
Spine.
spine.
It's the spinal cord, and usually they're
Mhm.
born with a sac outside the body that has the meninges in it and the nerves.
Oh yeah, duh. That makes
So if they
sense.
push, they can pop that sac. That's really bad.
But
Hydrocephalus.
usually-
what's that?
Like fluid on the brain, water on the brain.
So what happens if they push?
Increased pressure.
Increase ICP.
Yeah. Usually by the time that they're old enough though, because you don't give it to the infants, right? Isn't
Yeah.
spina bifida usually already corrected by the time that they would be getting something like this?
Spine. Well, wait. What do you mean?
Because the sac on the outside, right? Aren't they gonna
Yeah.
fix that before they're old enough to get a rectal suppository?
Yes, but when babies are born, they have to do one rectal temp on
Oh, so
every
you won't
baby
even
to
do
make.
that.
Well, UTMB hospital still does rectal temps on all their babies with all vital signs, which has been out of practice for at least 5 years. But they still, one of my students told me they still do that. What is supposed to happen, what is evidence-based practice, is we do a rectal temp on all babies when they're born, just to make sure that they have an anal opening, okay, to make sure that it is perforate.
Mhm.
Then we go to axillary temps after that, because repeatedly, sticking something in a baby's bottom is frowned upon, okay? But there are some hospitals that aren't doing that, okay? So in the case of a baby born with spina bifida, I would not do the rectal temp, right? That one time. And if like they get spina bifida babies at UTV all the time, they would be a nothing for rectum.
I
Yes.
see.
Okay.
Mhm.
All right. Do we understand vaginal and rectal administration? That was fun.
Yes.
Moving on. Okay. Let's see. This one. All right. What does parenteral mean?
Through the blood
Um,
vessel.
Mhm. We're going through into the blood supply. So this is giving a medication directly into some kind of blood supply. Okay. Let's see if you know these. What's IM?
Intramuscular.
SQ?
Subcutaneous.
ID?
Intradermal.
Intradermal.
IP?
Intra
Plural.
What?
parenteral.
Peritoneal. Where's the peritoneal space?
The peritoneal cavity.
Where's that?
The lungs.
Abdomen. It's abdomen.
Yeah.
Okay. You're thinking plural, which they sound just the same. IO. What's an IO?
Intraosteal.
Intraosseous, which is inside the
Yeah.
Bone.
bone. IV.
Intravenous.
Intravenous.
IA.
Intraarterial.
Intraarterial. IC.
Intra.
Intracranial.
Cardiac.
Oh, yikes.
IS.
Intracecal. No,
Spinal.
spinal.
So there's lots of different ways that we can get it into the blood supply. Okay.
Mhm.
All right. Needles. You'll know the gauge is how big around it is, right? And the length is actually how long the needle is. So you have to choose both, and you get to choose the gauge and the length. So you need to understand what you need to choose. Okay. Do y'all know the different parts of the needle, like the hub, the shaft, the bubble?
Yes.
We good on that? Okay. In needle sizes, the bigger the number, the smaller the needle. Right? Like an 18 gauge needle is freaking huge. Okay. A 30 gauge needle is teeny tiny small. Okay. To give you a frame of reference, if you have a piercing, they use a 14 gauge, and that sucker's like a fire hose. Okay.
Don't 18, like if like trauma patients or if they're gonna get blood transfusions.
For an IV, yes.
Okay.
Yes. They come in lengths. If you're doing a needle length, like to give an IM or something or a SubQ, they come, usually the most common you're going to use is 1/2, 5/8, or 1 inch. That's the length. Okay. As far as the syringe, have y'all seen the Luralock syringe? Y'all know what a Luralock is.
Yeah.
It screws on, and then the non-Luralock, you just put it on this way.
Yeah.
Use the smallest syringe size for the medication. What I mean by that is, let's say you're giving a solution to a patient that is 3.5 mLs of solution. What size syringe will you choose?
Say it again, 3.5.
It's a 3.5 ml solution that you're about to infuse.
So you're gonna use a 5 ml?
You're going to use a 5. What if it is 2.5? What will you use?
3
Three.
ml.
a 3, because it comes in 1, 3, 5, and 10, right?
Mhm.
The only exception to this rule, and this is very important and very testable, when you have a central venous catheter, okay, that could be either a PICC line or it could be an actual CVC, a portacath, any kind of CVC, you have to use a 10 ml syringe or bigger. It will pop and pop off the end of the catheter because the smaller the syringe size, the higher the pressure inside the catheter. So when you're going to give meds in a CVC, you have to use 10 mLs at least. You cannot use anything smaller, even in PD, because it will increase the pressure. Let's say you put a 5 cc on there and you push it, it's going to pop off the end of that catheter. And then where's that catheter going? Where does the
Through the
CVC go?
circulatory system into the
It
heart.
goes right into the heart. CVCs go right into the heart. So now you've put a piece of plastic right into their heart. Probably ought not.
Yeah, maybe.
Okay. Do y'all know what a carpy jet or a tubex is?
No.
No.
Okay, let me show you what this looks like. Y'all probably seen them in practice. So
SpongeBob's orders. Did you see that?
no, I didn't see it. What did
It
it
said
say?
mom stabbed her 3-year-old daughter according to SpongeBob's orders.
Oh dear Lord.
The SpongeBob's orders?
Humanity
Yeah, it said,
just
like-
needs to be eliminated. Okay. So this is a carpy jet. Okay. It will screw onto your syringe. Okay, I'm gonna show you a couple of pictures so you can get an idea. So it looks like this whenever you grab it, but what it will do is you see the syringe actually fits inside of it and you screw this onto the syringe that already comes pre-filled like this.
Mm.
And then it has this big giant plunger that you can use. Okay. Oh, it may look like this. UTMB uses these. So it looks like this, and you'll actually screw that into the pre-filled syringe. You screw this part right here until it tightens, and then you can use it to administer.
Okay.
Okay, because the syringes that are pre-filled, you can't really put it doesn't have a plunger on it. So this is the plunger that you're attaching to it.
Mm.
Does that make sense?
Yeah.
Yes.
Okay, where was I? All right. Okay, safety. Now this is a big NCLEX thing. Sharps containers are like priority over freaking anything. They are really big on Sharps containers. When they are full, that is a huge safety concern and you need to change that immediately, okay? All needles have to go in the Sharps container. Y'all know never to recap needles, yes?
Yes.
And if they absolutely make you on an exam, then you do the scoop technique with one hand, right?
Mhm.
You do not recap like this because you will stab yourself, okay?
Mhm.
Do y'all know what an ampule is?
Yeah.
Yes.
Okay, so make sure when you're opening the ampule, you always open it away from you because it's glass and you use gauze, otherwise you're gonna cut your finger because you're literally breaking the glass. So when you hold it, don't open it this way because you'll, and then you're gone, okay? You take the glass ampule with a gauze and you open it away from you. You understand that?
Yes.
And because it's a possibility, since you broke glass, that there are little glass shards inside the ampule, you have to use a filter needle to pull out the medication. Once you've pulled out the med, then you switch out the filter needle for the regular needle that you're going to administer to your patient, because the filter needle is huge. Do you understand what I'm saying?
Mhm.
Yeah.
Okay. Never administer a solution with precipitate. This is a big nursing red flag. If they ever say you drop a medication and there's precipitate, which basically means like little pieces of God knows what in there, don't give it. It means it's gone bad. Okay. Do you understand?
Yeah.
Yes.
All right. Preventing infection. Make sure you use the Sharps always and forever. Maintain sterility. This is vital. You clean the skin with alcohol from the inside to the outside, right? And you have to allow it to dry. It does not work if it's wet. The only way alcohol works is because it dried. If it does not dry on the skin, then it is not protecting your patient from any type of infection. You usually need between 10 to 30 seconds to allow the alcohol to dry. Are we clear?
Mhm.
Yes.
If you are accessing a PICC line or a CDC, alcohol is not the best solution. Chlorhexidine is. And this is the only time in nursing school that you can use the word vigorously. Okay, usually in nursing school, if you see the word vigorously, it's a big red flag, never use it. But when you're scrubbing the outside of a hub of a central line, and we know a central line goes right to the heart, we are going to scrub with chlorhexidine. allow it to dry, and then you can access the port. You understand?
Mhm.
Okay. Okay, I told you about the ampules to make sure that you use gauze away, use the filter needle. Y'all know when you are.
Sorry, I'm having trouble hearing you.
What the? They're always watching. Okay. Do not touch the needle to the rim. And if you're seeing on this whole module, we don't touch anything to anything. Have you felt that? Not the
Yes.
eyes, not the nose, not the ears, not the ampule. Okay. Vials. You'll know what I'm talking about, little vials of medication.
Mhm.
They're
Yes.
usually good for 24 hours. So as soon as you open one and pull off the top, you need to label it with the time and the date, and they're good for 24 hours. If you see a vial and it is not labeled, you have to chunk it because you don't know how long it's been sitting there, right? Right?
Right.
Mhm.
You're going to inject air into the vials. You do not inject air into an ampule or it will all over you. Do you understand the difference?
Yes.
Yes.
Okay, because an ampule, y'all know, is like open. You have to invert the ampule and then pull it up with a filter needle. If you touch the needle to the side on an ampule, the whole solution will come out and dump all over you, okay? But a vial, you pull up the same amount as you're gonna pull up. So let's say you're pulling up 1 ml, you pull it up with air, inject it into the vial, squirt the air in, then you can turn it upside down and pull up 1 ml. Are we clear on this?
Yes.
Mhm. Yes.
Okay. If you are using a multi-use vial, if the top has already been popped off, so make sure you clean the top with alcohol and allow it to dry. Are we clear?
Yes.
Okay. Mixing meds. This is very testable. Okay. If you are mixing meds, one of the meds is in a vial and one of the meds is in an ampule. You're going to draw up the vial first and then draw it up from the ampule. Because if you draw it up in the ampule, then you really can't put air in the vial, right?
Mhm.
You're going
Right.
to pull up the air, put it into the vial, draw it up from the vial, and then do the ampule. If you're going to mix meds, you always have to make sure that the 2 drugs are compatible. We don't mix more than 2 drugs. Okay.
Mhm.
Also important to note, if you're doing a multi-dose vial, which means you're pulling from the vial lots of times, and then you're going to pull from a single dose vial as well and mix those 2, you do the multi before the single. That way we don't mix the single with the multi. Okay, so multi-dose before single dose. So do you understand what I mean? You're going to pull it up from the multi-dose and then pull it up from the single dose. That's how you mix meds. Do you understand that?
Yes.
Yeah.
Okay. If you are doing 2 multi-dose vials, you have 2 that you are using that are multi-dose, you're going to use them multiple times. Okay, you've got vial 1, vial 2. You're going to put air in vial 1. Then you're going to put air in vial 2. Then while the syringe is still in 2, you're going to draw it up, take it out, and then draw it up from vial 1. This is highly testable. Are we clear?
Yes.
Okay. Mixing insulin. So you know insulin's measured in units, not mLs. Yeah?
Yes.
Okay. You always use an insulin syringe to pull up insulin. It comes in a 100-unit insulin syringe. You cannot mix Lantus or Levemir with anything. How come?
Because they're fast acting,
They're long acting.
long acting.
Yeah, these are long acting, so you don't mix. Okay. Rapid acting and NPH, if you're giving those 2 together, those have to be given 15 minutes before a meal, but the meal has to be in front of the patient. Have you ever waited on dietary before?
Yes.
So if you know, like, oh, breakfast gets delivered at 8:30.
And it's 10:45.
Exactly. So when you're giving insulin, the breakfast has to be in front of the patient, or whatever meal has to be in front of the patient. We can't be like, oh, they'll probably be here in a few minutes. And then you give a massive dose of insulin, the patient's like, ah, you know what I mean? All right, y'all know insulin has to be verified by 2 nurses. So before you give the medication, you got to pull it up and then compare the units, because you can kill someone with insulin. Yes.
Yes.
If you are mixing, the rule is RN, which is what you want to be, right? Regular before NPH. So regular first and then NPH. We always go from clear to cloudy, clear to cloudy, clear to cloudy. You got this.
Mhm.
Yes.
Okay. Do we understand parenteral administration?
Yes.
Yes.
Last one, guys. We got one more and then we're done. Do not panic when you see it. Okay. I'm not going to read this whole thing to you. You guys can actually do this on your own. but I need to explain it to you before you do it on your own, because it's a bunch of like little tiny things. So this is just a cheat sheet I made for you guys that tells you the different type of routes. Like we've got intradermal, SubQ, IM, and IV. I gave you a description here, like where it goes. Like for instance, intradermal, we know goes right underneath the skin, right? Here are these sample needle sizes for each of these. So you need to be able to match the needle size with whatever route that you're giving, okay? So for instance, we know the intradermal is right underneath the skin. So it's gonna be super tiny, right? Like 1/4 to 1/2 inch. Subcutaneous is the next level, so it'll be a little bit bigger. And then intramuscular is the deepest. So you'll see that 1 to 1.5, okay? And then you have the gauges that you typically use with each of these. All right, intradermal is right underneath the skin, so I only need a teeny tiny needle, right? Our IM administration, some of those can be really thick and viscous, so we have to use a bigger needle. Okay, I will tell you all across the board that vaccines are always 25 gauge, always. So where you see like vaccines V, I put the V's over here too, where you're going to give the different vaccines because that's highly testable. Okay. Then the next one is location. So where are the best places that you can give these injections? Okay. After that is the angle. This is highly testable. You have to know exactly at what angle you are going to inject each one of these. Okay. Then how to administer. So this will tell you what type of syringe to use. I mean, a lot of this stuff you already know, but these are big testable things. Like when you're giving an intradermal, the bevel or the opening part, right, has to be up. You've got to create a wheel. Don't rub it. Don't scratch it. So these are your big testable things that you need to know. I'm just going to point out the big ones. I'm not going to read this whole thing to you, but like SubQ, very important that the abdomen is the best place to do that, but it has to be at least 2 inches from the umbilicus. So please don't try to inject them in their belly button, okay? It has to be at least 2 inches away from the umbilicus when you're doing the abdomen, okay? If it is more than 1 ml, you need to put it into 2 syringes, okay? Because it's not going to absorb very well and it's going to cause tissue damage, okay? If you have a very thin patient, make sure you pinch up the tissue because a regular size SubQ needle will go too deep for your really skinny patients, okay? Or like little ladies, you know. Do not massage the site. Never massage sites after we give something. It can cause tissue damage, okay? Let's see, on IM, I can guarantee you're gonna have location questions. So you need to know at what age, which muscle that you're going to give it in. And you definitely need to know your landmarks, okay? Do y'all know what I mean by landmarks?
Yeah.
Yes.
Okay. And I gave y'all a cheat sheet for that too. All right, I'll show you that in just a second. For iron and other viscous meds that are really damaging, use the Z-track method. Do y'all know what the Z-track method is?
Yes.
Yes.
Okay. And then I gave you a cheat sheet on IV solutions. This is very important. What's the first thing you do if you get a needle stick?
Wash hands with
Wash
soap
the
and water.
area.
Wash your hands with very warm water and soap for at least 5 minutes. Ideally 10 is better. Then you're going to go report it to your charge nurse and be like, I've unstuck myself. And then she'll send you on to the ER to get prophylaxis and get your blood drawn.
10 minutes?
Oh yeah. Wash
That's
that
freaking
stuff
crazy.
out.
You're just like
Yeah.
standing there. Hey.
All right. Let's see if there's other big things that you may not know. If the patient says that their IV site hurts, stop it for a second and assess. There are some medications that just hurt when you give them, like potassium hurts, calcium hurts, but assess the site, make sure it's flushing really well. If you assess the site, it's nice and flat, it's not swollen, it's not red, it flushes good, then you can either slow down the infusion or try to dilute it with more normal saline. Okay?
Okay.
Let's see, admin options. Y'all know what a bolus is?
Yeah.
It's like a lot all at once.
Yes. Piggyback.
It's like
That's,
you give it after something.
Where it hangs like higher.
Mhm.
Yes.
It hangs
And
higher
but
than-
you're giving it with an IV infusion solution. So they'll get it with their normal saline. What's a heplock?
Yeah, I don't know what heplock is.
Yeah, I don't.
All right. What about a saline lock?
Is that where like when someone has a like an IV like already in them and it like it just like it's a place where normal saline can go in?
Yeah, but it's not. So like, yes, you're right, but normal saline is not infusing. So anytime you see the word lock, there's an IV in place, but it's not connected to fluids.
Oh, okay.
It's sitting
Okay.
there for whenever you need to use it. Like, let's the patient doesn't need fluids anymore, but you're still giving antibiotics every 4 hours. You'll just do a saline lock, which basically means I push saline in it to make sure it stays patent and open, and then I clamp it, and then it's just sitting there. A HEP lock is the same thing. The IV side is there, but it's not connected to anything. But maybe I have a really big IV catheter in there, and I'm afraid it's going to clot. So I will push some heparin, which is a blood thinner, into the IV and clamp it, so that way it won't get clotted off.
Mm.
Okay. So if you see HEP lock or saline lock, that means they have IV access, but it's not connected to fluids.
Okay.
Okay. And then obviously y'all know what IV push is. Yes.
Mhm.
Now I put push over 2 minutes. That's the minimum amount of time. There are some IV pushes that may be longer than that. Okay. Do y'all know what an infusion pump is?
Yeah.
Okay. Always put all your meds on an infusion pump. We don't do those to gravity. Okay. Let's see if there's anything else on here that I have not said. Y'all know what a PCA is?
Yeah.
Okay. If the IV has infiltrated, what does that mean?
Means like it's
um
infusing into the skin and not the vein.
So it's puffy and red and painful and you can't flush. Stop the IV, stop the solution, restart somewhere else. Now, some catheters and IVs are big enough to where you will get a blood return. Some of them don't get blood return, but they're still good IVs. But if you don't get blood return, just make sure you do a really good assessment of the site. If it's soft, it's flat, and it flushes really well, you can go ahead and give the medication. You need to check an IV site a minimum of every 2 hours for signs of infiltration. Got it?
Yeah.
Okay. And then the last thing, I'm just going to show you this. I don't need to go over this with you, but I've included this cheat sheet for you. So it'll tell you
Oh, okay.
exactly how to do the procedure. They really like to ask about IM. So it'll give you your landmarks and exactly like what you need to know, because this is very highly testable. Okay. We made it. It only took 2.5 hours, but we got the Sorry I ran over, but it was a lot of information. Hold on one second. Let me stop this. Just 1 second.